Anytime there's any form of manipulation in any way, there is always a risk that you could be putting too much tension on those hair follicles. So I usually recommend you have to be very careful, and I try to encourage my patients to rotate between different hairstyles.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
You know, I'm doing pretty well. I've just been thinking a lot about hair, Hadar, and, all the different hairstyles I've seen you in over the past couple of years.
Thank you. I appreciate that compliment. And absolutely, I've been working on my hairstyle. My style varies from little to too little hair. But I know other people in our practice come to us with various complaints that have to do with hair. And some of the basics is really complicated, actually, and really confusing to dermatologists because we're very good at understanding the infundibulum. But when it comes to a hair curler, is that what you call it? We get a little tongue twisting. Don't you think?
You make me remember that one movie where it's like, you have a problem with your amygdala, remember? Or what was it? I forget what it was, but it's like, you have a problem with your infundibulum.
Exactly. So we're very eloquent at describing this to our patients, but we may not know what happens when they go back home, and we need someone to help us desperately.
Oh, absolutely. And we're pretty lucky today because we have Dr. DiAnne Davis, who is a board-certified cosmetic dermatologist, and she specializes in non-invasive facial rejuvenation, skin of color, hair loss, and cosmetic dermatologic surgery, and she practices out in Dallas, Texas. DiAnne, thanks for joining us on this podcast, and we are excited to delve into hair today with you.
Thank you so much for having me. It's a topic I talk about all day, every day, so I'm super excited.
I mean, first of all, I am so excited to find another fellow dermatologist that's actually excited about hair. Let me just start this off. Why is it that everyone groans about hair as soon as they're like, oh, they asked about hair? And it's like a big groan. Why do you think that is, Dan? And why do you think you've gotten so excited about it?
Well, I think part of it is that when it comes to hair loss or hair care, especially in our clinics, it's a lot of investigative background information you have to elicit from the patient to really get to what it is they're coming to see you for and to help diagnose their condition. So I know for some people, there's so many questions that we have to ask. There's usually twice as much information that the patient wants to give you about how they started styling their hair since they were 2 years old. And it becomes a very lengthy visit.
Yes, exactly.
I mean, they would like to go back to the very beginning. So sometimes it's just a lengthy visit that you really have to prepare your clinic and your staff and schedule for so that you can really, have that time to ask all of the questions that you need of the patient, but also give the patient the opportunity to feel like they are being heard as well.
I think one of the issues, as I alluded to in the introduction, is that there's a lot of times a lot of barrier between what the doctors think or see in clinic and what is happening at home. And I think especially this comes when the doctor and the patient are from different cultures, right? And I'm wondering if you can tell us, what are the top few mistakes that dermatologists often make when it comes to assumptions they make about hairstyling practices, especially cross-culturally?
That's a very good question, and I'm so glad that you asked that. I would probably say the top of the list would first be not actually assessing the hair. I have a lot of patients who will come to me and say that they may have been to go see a previous dermatologist who didn't look at their hair or didn't touch their hair. And I think sometimes with cultural differences, we all want to be respectful of our patients. And I know some of my colleagues may not know exactly how to transition the appointment into examining the scalp or touching the hair, or, they're maybe a little concerned. Maybe the patient doesn't want me to touch their hair. So I know sometimes I have patients who come to me and they say, well, they didn't even look at my hair or my scalp. I would say the second thing on the list would be how often, especially people with ethnic backgrounds, how often we wash our hair. Because the assumption is that everyone washes their hair maybe every day, every other day, or maybe every 2 days. But especially for patients of African descent, we will usually shampoo our hair maybe once a week, or maybe even every 7 to 10 days. So that definitely you'll have to change and adjust your plan when it comes to, putting together a treatment plan for the diagnosis, because we don't wash our hair every day.
And for those of us who don't know, why is that? Why not wash it every day?
So our hair, again, we have more of a curlier or coily texture.
Right.
Our hair tends to dry out faster, and our hair strands are more fragile and, afro textured hair. So that's why we don't wash our hair every day, because it would be too drying for the hair, and it would definitely lead to more shedding and excessive hair loss just because of the drying process.
Right. And I think there's a lot of, assumptions. I know when I was a resident just starting out, it was very surprising to me. I grew up always thinking, oh, you wash your hair every day. No. And so I think that is very helpful, and understanding also why, because I think we're used to hearing that answer, about once a week, once every 10 days or so, but never bother to ask why. Why is that? What happens if you will do it every day? Is there another thing that you think is usually a barrier when it comes to cross-culture kind of translation?
Let me think back. Well, I was going to say another thing too on why we don't wash our hair on a more daily basis, if you will, is also we spend a lot of time doing our hairstyles. I mean, especially, in the African American community, we will spend 4 to 5 hours in a salon to get our hair done. So once we have that hairstyle, if it's something that is a little bit more stylized, where we don't really manipulate the hair on a daily basis, we tend to keep that hairstyle longer before we shampoo our hair. So that's another reason why we don't necessarily wash our hair, on a daily basis.
As a nerdy white professor, I want to say I spend that much time on my eyebrows.
Okay. I think you won't have much time to spend on your hair, my friend. Right?
Exactly. And I think that's important to actually, when I see my patients who have hair complaints, and even with seborrheic dermatitis, for example, right? We prescribe shampoo. That's the most common thing we will do in practice, I believe. So when I see my patients who are of African descent and have this amazing hair, I'm so jealous. And I think I just want to kind of break the ice, and they look at me and I see that. And I think acknowledging the kind of elephant in the room to say, hey, I know I didn't grow up as you did. I'm this white nerdy professor standing here and trying to tell you, wash your hair every day because it may be better. So just acknowledging that barrier that we have, I see a huge relief in the patient's eye. Maybe I'm imagining, but just to say, I understand where you come from. We can work around that. Don't worry about it. It's okay. I think just that is a huge relief, because like you said, patients may go through different providers who don't even look and touch. And I think doing a thorough exam of the scalp and hair is critical. Forget, even if you don't learn, even if you knew the diagnosis from the moment the patient walked in, at least they feel like they got their money's worth. And I want to tell you that very often I do find new subtleties, and it will change my management. So definitely excellent tip and worth your time if you're listening out there.
Right. Absolutely. Sometimes I'll even see, other, lesions that I might be concerned, might either be benign or malignant, that they may not be aware of. So like you said, it's really important to make sure to do a thorough examination.
All right. So now let's dive into these hairstyling habits that you call high risk. What are those high risk ones that really we should be on the lookout, because they could be culprit in some of the disease states we see?
So these are going to be hairstyles that are going to apply more tension on the hair follicles. So whenever the hair is manipulated in the way where it's not kind of naturally just growing out of the scalp and falling the way gravity wants it to fall, you always have to think about how much tension is being applied to the hair strands and the follicles. So some of these hairstyles are going to include braids, braids that are going straight back, or sometimes we may refer to them as cornrows. Sometimes these are going to be the hairstyles that we may see like, rappers, wear in their music videos or whatnot. But that can be a very tension-provoking hairstyle. Oftentimes, a lot of women may wear sew-ins, and this is where their hair is actually braided underneath. And then, synthetic hair is sewn on top. And so not only do you have the braids that may be causing tension, but then you're also having this needle and thread being wefted through the hair to sew additional hair on top. And so that can add a second layer of tension.
How does this relate to like extensions? Because I know that a lot of women will have extensions that are weaved in as well. And I'm assuming those extensions can put a lot of tension on the hair, especially if they're longer and they get wet. And they typically use real human hair, right? In many of these
Right.
scenarios. What is your thoughts on that? Would that be under the same sort of an issue of tension, or do you think of it differently?
No, it definitely can be. I will say it may depend on how the extensions are put into the hair, because we have extensions where they can have small little pieces that are clipped onto the roots or the base of the hair follicles. You have some, again, where the hair is braided and then they're sewn on. Lately, I've been seeing in the media, they have these tape-in extensions. So I guess it's like this, the human hair is weft onto almost an adhesive tape and you tape it to the scalp. So I think there's a lot of different ways, there's a lot of creative ways where we are seeing either stylists or companies try to make unique ways that extensions can be added without causing a lot of damage or tension onto the hair. But I try to explain to my patients, anytime there's any form of manipulation in any way, there is always a risk that you could be putting too much tension on those hair follicles. So I usually recommend you have to be very careful. And I try to encourage my patients to rotate between different hairstyles and not do the same hairstyle time after time after time, because the repetitive nature could also be adding another component to the tension that's being placed on the hair.
Yeah, thank you for touching on this, because I'm always hesitant to say, hey, this is how the person wants to wear their hair. So maybe take us through what's the cycle that this would take, right? So to switch from cornrows to extensions, how long does each hairstyle last in a way, or, you would tell them to keep it on? Can you expand a little bit about the kind of time cycle that this would require?
Sure, that's a really good question as well. So ideally for cornrows or maybe extensions, I try to have my patients agree to 4 to 6 weeks max. Okay, I try to see if we can agree to that. Oftentimes, you will have patients who will come in and they will say, oh, I will leave my hair like this for 3 months. And I tell them it's just too long and they're not giving their hair or their scalp a chance to breathe. And if they have, a form of hair loss, if they have seborrheic dermatitis, all of that is brewing underneath and it's not being addressed, as thorough as it can be, because they're not able to reach, their scalp. So ideally with cornrows, I prefer even 3 to 4 weeks with cornrows. If it's extensions, I prefer them to not go longer than 6 weeks. And then I will usually tell them to take it out. And then I will recommend that sometimes to give their hair a break, maybe they can consider a wash and go, where if their hair is super curly, they can wash it, apply a little bit of product. And then it's almost as if just their wavy curls are just exposed and just naturally, falling, how they want to fall. Sometimes I may tell them if they want to go and have their natural hair straightened so that at least they can still reach the scalp, to do our treatments. That's another option in between the braids or the sew-ins or, some of the more stylized hairstyles.
Well, clearly there's a lot of talking and listening going on, so that's for sure.
Yes.
But at least you give us some tools in how to navigate this conversation, because it can be very tricky. And I think the first thing I learned in medicine is that you can know all the textbook you want, but if the patient is not going to buy into the treatment regimen, who cares,
Yeah,
right?
no kidding.
You mentioned product, and as we're going through different hairstyling habits, I want to touch on that a little bit. Can you tell us about various products, greases, and how you navigate that conversation? Because sometimes that can also be harmful, but on the other hand, it is necessary. So where do you find the common grounds on that?
Right. Sometimes I will have my staff, if we have enough time, I may ask them to tell the patient to bring in whatever products they're using on their hair so I can assess them. You have to be careful though, because sometimes patients will bring in the entire Target aisle of all of these products.
Careful what you wish for.
And then that can definitely, it can definitely add on to the length of your appointment. But I do like to ask my patients, what consistency do they like their products in, because we have greases, we have oils. Some people like to use a mousse, or some people prefer a liquid. And so I usually will ask them what products they're using, because as we're starting to see just in the literature and coming out, is I'm more cautious of a lot of these products may have chemicals that are considered endocrine disruptors. And we're seeing a lot of connections between sometimes some of the different ethnic hair care products and their relation to fibroids, in particular in the African American community. So we have to moisten our hair. Again, our hair tends to dry out extremely fast. So we do have to use certain products that will continue to keep our strands hydrated. But I try to go with very light products instead of more heavier grease pomades, because too much of that can sit on the scalp, and that can definitely even feed possibly seborrheic dermatitis, or it's just not allowing any medications that we're prescribing to penetrate into the scalp to do what we want them to do. So I tend to stick with lighter oils versus heavier greases and pomades when it comes to hair care products that I recommend.
Oh gosh, I really love how you're approaching this, because this is the same challenge that I've seen, which is that you put on things that are just too thick because you think you're supposed to, quote, nourish the skin by just sticking all this stuff on, and all you're doing is nourishing the malassezia.
Exactly.
It just thrives, So it's like creating a little, we don't want to put any branding here, but it's Kaiser for the little malassezia to thrive, I suppose. But
right.
Anyway. So what I wanted to ask about, especially in this realm of scalp care versus hair care, how do you differentiate the two? I mean, a lot of people focus on their hair and maybe they treat their hair, but is there a different way to approach, say, hair? Can you put the thicker oils or like just put them through the strands on the hair versus what you put on the scalp? How do you approach the difference?
Excellent point. I always make that to my patients. Yeah, I'm curious to hear what you think.
Yes, you definitely can. So, we'll take, what I definitely commonly see, which is seborrheic dermatitis. And I still do recommend, either the over-the-counter or the prescription strength shampoo. And I explain to my patients, for that, I tell them to apply it to their scalp only. I often now will tell them to apply it to their scalp when the hair is dry, or they can mix a little bit in a spray bottle with water and then kind of spritz it onto the scalp. Of course, let it sit. And then when they rinse it out, I have them focus a hydrating shampoo onto the strands of their hair. If it comes to something like a prescription strength oil, where we would like for them to apply it to the scalp and potentially maybe the strands, I will tell them to do almost like a hot oil treatment the night before it's their shampoo day. And I'll tell them they can actually let it sit on the scalp and the hair strands, put a shower cap on, tie a towel around it, go to sleep at night. And then in the morning, you can rinse everything out, do your regular shampooing regimen. And then from that point forward, we're focusing the oil on the scalp only and not the hair strands. For prescriptions, I will often alternate when they're putting it on the scalp versus their strands of hair.
No, that makes a lot of sense. Thank you. And often I do make that separation of scalp and hair because I think patients often have that confusion. So, Raja, to your point, I totally agree. And this question, actually, Raja, may also go to you, because some patients come in, speaking of oils and ways to nourish the scalp, the follicle, the hair, and are asking for natural oils. So I know, Raja, you dab a little bit in that stuff, so feel free to chime in. But do you have any preference? Do you suggest any, like a coconut oil or other products like that?
I personally like pumpkin seed oil. That is one I like. There are a couple that have a little bit of aloe vera. I think those are okay. I'm a little cautious with coconut oil. I'd love to hear what Raja says, only because sometimes coconut oil can be too thick.
Oh my gosh, I totally agree with you. Yeah, I'm a big pumpkin seed oil fan, so put me in your fan club.
Okay,
for that
I
one,
love that.
Because I think it's the only one that's got some real good evidence reasonably, right? They've got the topical study, they also have the oral study. And then do you ever put any bit of rosemary in there? I know that's been in some other studies. It wasn't in the pumpkin seed oil itself, but I will ask people to get some rosemary essential oil and just put a couple drops in, but test first.
Right.
In case you have allergic contact dermatitis.
Right. Absolutely. Yes. I like rosemary as well. I will tell you, in the past, I used to like peppermint oil and tea tree oil, but I've recently been hearing from some of our colleagues, with that menthol, sometimes we may think that tingly feeling, is soothing and it's doing something, but sometimes if they have an inflammatory process going on, it can add to the inflammation. So I have
Interesting.
personally backed off of recommending tea tree oil and peppermint oil.
That is so interesting because I know tea tree oil has that antifungal
Correct.
branding to it, and it probably does. But that's very interesting because I don't see everybody improve on tea tree oil. So perhaps there is something to that. Maybe there's some counteractive issues.
Right. Yeah. But I
on.
used to love it, but I kind of started backing off of recommending it.
Oh, have you? Yeah. No, I still tell people to use it, but I
Okay.
usually put it in the pumpkin seed oil. But maybe I need to pay attention to that. Do you ever use sunflower seed oil? I know there's been some studies looking at it for dermatitis. And so I've kind of expanded to think about using it for seborrheic dermatitis on the face and had them use it on the scalp a bit. But what is your opinion on that?
I haven't tried sunflower seed oil. That's a good one I may have to try though. I haven't tried
You may
that
smell like a baseball dugout though, if that happens.
Okay. Okay, no,
I don't
and
know.
that's something important to tell patients. I've learned this as well when it comes to different things we may be prescribing or compounding, especially for the hair and scalp. If you notice or if you have feedback that it does have a smell, definitely tell patients.
Okay, since we're talking hair and we've been talking about tips and little tricks, can you talk to us about, do you do much with PRP injections? And then secondly, oral minoxidil. Can you comment on both of those?
Yes, I love them both and I do both of them, in the right patient setting for the, proper diagnosis. I find that when I talk to my patients about topical minoxidil, a lot of them would prefer the oral because they find it easier in their schedule to take something by mouth than having to think about applying it to their scalp on a consistent daily basis and sometimes twice a day. So I have a lot of patients who actually prefer the oral form. I personally take the oral form as well myself. And I actually slowly titrated myself up just to see what is that sweet spot on where I'm getting improvement, but I'm not necessarily developing too much hair in other places because that does happen.
Is that the major side effect, Diane? Is it the hair
Yes.
growth in other places?
Right.
I
Yes.
see.
And I believe, in one of the studies, they reported that it was 4% of hypertrichosis. I have probably seen it. I guess I would probably say maybe about 3% of my patients I have personally seen it in. So I would usually just back down on their dosage and they would normally do fine. So I find somewhere between half a tablet to a full tablet is where is the sweet spot for my patients in terms of oral minoxidil. But I also do love to incorporate PRP into my practice as well.
Yeah, so with platelet-rich plasma, do you have like a particular frequency that you like to do the injections? And the other question that relates to PRP, do you tell people to eat any particular diet to enhance their blood full of certain antioxidants or certain factors? Because I don't think that's really been studied, and I'm really curious to hear your thoughts on that. Do you have them eat certain things before they come in for PRP, or maybe cut things out that might be not so great to have in your bloodstream before you draw and get the PRP?
That's an interesting point. I don't tell them to eat certain things. I will tell them to just, the 24 hours before, make sure they're extremely hydrated, just so that we can, of course, obtain their blood. I did have a couple of people who were smokers. And so for them, I really had to have kind of a, come to Jesus talk with them about, because we weren't really able to even draw their blood. They were hard sticks. And then they had multiple, comorbidities as well. So I had to have a come to Jesus with them on what's more important, the cigarette or the hair. And, slowly kind of get them to realize, like we may be counteracting, we may be canceling each other out, if we don't, try to focus on, just some healthier lifestyle choices. But I recommend for my patients to do 3 to 5 treatments 4 to 6 weeks apart. I tell them to not go beyond 6 weeks because we really want to make sure we're kind of getting that bang for our buck. And I have found that usually my patients between injection number 4 and 5, that's where I start to see the magic happening. For some patients, it does take a little bit longer. So I used to recommend only doing 3. And then slowly with my practice, I've started to realize the patients that I'm doing, that 4th and 5th treatment on, I feel like that's when we're really starting to see the improvement. So I try to counsel my patients on 3 to 5 treatments. But as we know, insurance doesn't cover this, and it can be costly for some patients.
Absolutely. And you're probably focused on combination therapy too, right? At the same time, you're probably
Correct.
got them on something topical, I imagine, or something oral.
Something oral.
Gosh, I would love to see a study where they're looking at nutrition or some supplements to see how that changes the PRP character, because That would be very interesting.
Right. I think you have a point there. I definitely do.
Well, DiAnne, listen, this has been a very hairy conversation, but it's been lush, full of information. I mean, how many puns can I do in a row?
Maybe in a cornrow, maybe.
Oh, God. There we go. Okay. With that, I have to say the two of us were meant for each other, Hadar. And also, DiAnne, we really appreciate your time today. I know this is an area that a lot of people have a conversation about. And those groans and moans hopefully will turn into like yelps of excitement to say, hey, there are things we can talk to our patients about now. So we thank you for your time and thanks for joining us today, DiAnne.
Absolutely. Take care.
Hey, Raja, do you know where the integrative medicine movement started?
According to Google, since Google knows everything, Dr. Andrew Weil founded the Center for Integrative Medicine at the University of Arizona in Tucson back in 1994. Why do you ask?
Well, you know how we always try to get to the root cause? I think we need to go big for the fifth annual Integrative Dermatology Symposium. How about we do this? Let's meet at the Los Ventana Canyon Resort in Tucson, Arizona. Or you can join virtually from September 30th to October 2nd and hear from the world-renowned experts like Andrew Weil.
Exciting. And our theme is connecting mind, body, and spirit to take a more holistic approach to our patient care. What do you say?
Absolutely. I mean, where else can you get the latest on diet and dermatology, hypnosis, botanicals, common diseases, aesthetics, and other unique topics in dermatology with practical takeaways to start using in clinic right away?
So true. And let's not forget, we've got the new track for estheticians too. I think I'm going to need to call in a sick day or two before the symposium so I can enjoy the waterfall and trails on the resort, stargaze, play a round or two of golf or tennis, relax at the spa, and catch up with colleagues at the evening receptions.
Yes, that place is spectacular. Use our discount code POD25 at checkout for 25% off.